Good afternoon, everyone. On behalf of the Association of State and Territorial Health Officials, also known as ASTHO, I would like to thank you for participating in today's webinar entitled, Are You Ready to Sail Your Ship? Today's webinar is being recorded, and you will receive the link to review the presentation at a later date. My name is Denise Pavletic, and I'm the Director of Public Health Systems Improvement here at ASTHO, and I will be moderating and presenting during today's session. This webinar is the first in a series of 4 webinars that ASTHO is hosting on the topic of developing a state health improvement plan. Today's webinar is brought to you through funding and partnership between ASTHO and the Centers for Disease Control and Prevention, Office of State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. The information provided in this webinar is intended to be consistent with the PHAB requirements. However, ASTHO cannot guarantee that states who follow this guidance in the guidance in this document will meet the PHAB requirements, because only the PHAB site visitors can make that determination. Our objectives for today are: identify the tools available to assess your agency's readiness to convene a SHIP partnership, identify and engage key stakeholders in the SHIP development process that reflects the public health system, structure the SHIP planning group to be effective planners, and then to understand how to incorporate systems thinking and collective impact framework into your mission, vision, and value statement. At the conclusion of this webinar, you will be directed to a link to answer a few questions on how well we have met these objectives. In the spirit of our own QI, we very much value your feedback, so please take a few moments to complete the evaluation. We're very excited to bring you today's webinar, and we look forward to a robust Q&A session at the end of the presentation. If I can take a moment to orient you to the ReadyTalk platform, there are 2 ways in which you can submit your questions. The first is through the chat function located on the lower left corner of your screen. You can submit questions at any time throughout the presentation using this function. Your second option is to hold your question until the end of the presentations, at which time our operator will open up the lines for you to address the presenters. So I'm very happy to say that we are joined by our colleagues in Alaska and Oklahoma. Michael Dickey is the Quality and Performance Improvement Manager for the Alaska Department of Health and Social Services Division of Public Health and serves as the co-chair for Healthy Alaskans 2020. Over the past 15 years, Mr. Dickey has worked on national, state, and local health initiatives in the areas of performance improvement, coalition development, health equity, behavioral health, and policy, systems, and environmental change. Mr. Dickey has a master's in public health from the University of South Carolina. Our second presenter from Alaska is Dr. Diana Redwood. She is a senior epidemiologist at the Alaska Native Epidemiology Center, Alaska Native Tribal Health Consortium. Her professional expertise is in public health and epidemiology with a focus on cancer screening and prevention. She has worked at the consortium since 2004 and managed colorectal cancer projects at the consortium for the past 7 years. Dr. Redwood received her Master's of Public Health and Master of Science in Nutrition from Tufts University and her PhD in Public Health from the University of Alaska Fairbanks. And then in Oklahoma, we are joined by James Allen. James Allen is the Director of Partnerships for Health Improvement within the Oklahoma State Department of Health. Mr. Allen has 17 years of public health service, having worked both in state government and in higher education with an emphasis on systems and community-based approaches to reducing behavioral risk factors. Mr. Allen is also a master trainer with QPR Institute, and that's a national and international provider of suicide intervention training. He is currently the president of the Oklahoma Public Health Association and past president of the Southwest College Health Association. And he received his master's in public health from the University of Oklahoma Health Sciences Center. So in the summer of 2015, ASTHO released our Developing a State Health Improvement Plan Guidance and Resources. And this is a companion guide to our State Health Assessment Guidance and Resources that we released in 2014. I did want to take a moment to thank and to recognize the partnership between ASTHO and our colleagues at the Illinois Public Health Institute in creating this guide, and also recognize our expert SHIP Advisory Committee, and some of you may be on the call today. So I'm going to walk you through a couple of screenshots to show you where you can find this resource. If you go to www.astho.org, you're going to click on Programs, and you'll see a drop-down menu. You're going to click on Accreditation and Performance. This will bring you to our Accreditation and Performance landing page, where you will click on Tools Clearinghouse under the Resources. And just a quick note, under Resources, actually in the Tools Clearinghouse section, we have several resources, including case studies, toolkits, peer network information, our Quality Connection newsletters, webinars, sample SHAs and SHIPs, presentations and fact sheets, and an accreditation library where we house example accreditation documentation. So please visit us there and peruse through those resources. Okay, once you click on the Tools Clearinghouse, it will bring you to the SHIP landing page, as you see in front of you, and you'll click on the download link. And just to give you a heads up, before the download begins, you'll be directed to complete your name, agency name, and your email address. We are using this information to provide follow-up on the toolkits and to use for our evaluation of the toolkit. The Developing a SHIP includes 7 modules, and those are identifying and engaging stakeholders, engaging in visioning and systems thinking, leveraging data inputs, establishing priorities, communicating about SHIP priorities, developing objectives, strategies, and measures, and then implementing and monitoring the SHIP. Of course, today we will focus on modules 1 and 2. And just a kind of a quick preview of what's in the resource. Each module contains a preview of the content, the associated PHAB standards and measures, ideas for structuring the planning process, some important considerations, key terms and acronyms, and then most importantly, our state examples and lessons learned, as well as tools and links to resources. And throughout the book, you will notice that we cross-reference the State Health Assessment Guidance and Resources that I mentioned earlier. Each module has an extensive list of resources and links related to the module topic. And then each module contains the relevant reference to PHAB Standard 5.2, as well as other related standards, Last, each module contains a section on important considerations with links to relevant resources. So that's just a quick overview of what's in our resource. Let's jump right into Module 1. And this module covers assessing your agency's readiness to convene a SHIP partnership that reflects the public health system, structuring the planning group to be effective planners, fostering leadership, engaging new partners in innovative ways, and providing tools for implementing effective meetings. Many of you are familiar with the egg diagram that displays a public health system. And CDC's definition of a public health system is public and private entities and sectors which contribute to public health services within a community. These may include civic groups, nonprofit organizations, employers, schools, and others. The State Health Department should consider developing a tailored diagram of the public health system that will resonate with a range of stakeholders involved in your SHIP process. And you'll see figure 1.2 is an example of a tailored diagram from Florida's public health system. Assessing readiness is a critical step to ensure success of the planning and implementation process and should be done early on to inform design of the process and timeline. A readiness assessment tool can be helpful to guide the SHIP steering committee in determining whether the requisite elements are in place to move forward. And here within the resource we've included a readiness assessment. States can take a number of approaches when designing the structures to support the SHIP process. Typically, this includes a formal partnership structure to ensure the development and implementation of the process, with work groups for each priority, as well as a measurement or evaluation work group to lead the creation, measuring, and monitoring of action plans for each priority. And then a sample structure to support development, implementation, and continued monitoring of the SHIP might look something like what you see on the slide. And again, this is an example from our colleagues in Connecticut. Some things to think about. A performance management system includes the setting of performance standards, measuring of progress, and reporting results, and then application of QI activities when improvement is needed. The performance standards are related to important administrative functions, programs, and services provided by or through the health department. A set of performance standards associated with your SHIP should be developed and incorporated into that performance management system. Module 2. This module covers development of a mission, vision, and value statement and provides guidance, resources, and examples of how to include concepts of health equity in the vision and values, as well as to incorporate systems thinking and a collective impact framework. Given the importance of addressing and improving the health of vulnerable populations, highlighting a focus on health equity in the vision and value statement may provide important guidance to the SHIP process. And here is figure 2.2 from our guide, and that's a sample from the Healthy Minnesota Partnership. Collective impact is frequently referenced in public health as an important framework for increasing the impact that can be achieved through collaborative work. Collective impact involves diverse stakeholders working across sectors who have a systematic approach to develop solutions to problems, build and leverage collaborative relationships, and work towards sharing objectives across organizations. The original collective impact focused on 5 conditions, and those are shown in figure 2.3. A useful concept for collective impact and adaptive problem-solving approaches is systems thinking. And here in figure 2.5, we see a high-level systems thinking framework for addressing public health issues. This model shows 4 interrelated components that are essential for taking a systems approach to addressing complex public health issues. So those are some of the highlights within our guidance. And now I would like to turn it over to our colleagues in Alaska. Michael and Diana, please go ahead.
Thanks, Denise. Can you hear us okay?
Yes, we can hear you.
Okay, great. First of all, we'd like to thank ASTHO for having us share some of our processes in developing our SHIP and also the role of our stakeholders. And so thanks to everyone on the call who took the time out of their day to join us. Diana and I will be quickly tag teaming throughout this presentation since it's only a 15-minute presentation. To begin with, just a little bit about Healthy Alaskans. Healthy Alaskans 2020 is our statewide initiative that's sponsored by the Alaska Department of Health and Social Services and the Alaska Native Tribal Health Consortium. HA 2020 supports collaborative efforts among many different sectors and agencies and communities throughout the state working towards common goals to improve the health of Alaskans. One thing to emphasize is that Healthy Alaskans 2020 is Alaska's state health improvement plan, and I'll probably reiterate that throughout this presentation. PHAB's SHIP requirement helps support the need for Alaska to develop a SHIP, and also with CDC NIFI grant that we had received a few years ago had really helped us propel this work forward as well. It's important to note that the State Health Agency, DHSS, and ANTHC are not Healthy Alaskans. We started it and we support it and we provide some administrative support and some technical assistance support. But really, this initiative and our SHIP is the collective action of all the different organizations, coalitions, businesses, and others working towards improving any of the health priorities that have been identified through our 25 leading health indicators. And this is something we emphasize continually to help create ownership, accountability, buy-in among all partners and potential partners as well, because we believe early stakeholder engagement has really helped to move the focus of our two initiatives to being into one entity. And you just saw this. Denise showed this. This may be a little different, but it's basically the same concept. This is a broad description of Alaska's public health system. And our state health improvement plan, of course, is most effective when all the sectors are engaged. We work to align these diverse entities who have common goals and entities and help to make those connections where groups don't see them. And although we have successfully engaged many of these, we are currently working to further enhance relationships with some groups. Those include city planners, the military, transit department, large employers, and nursing homes. So I think what we've done, at the beginning, we were ambitious and didn't have too much time, so we took the low-hanging fruit, looked at existing relationships, and went with what we could at the time, and so now we're continuing to build our stakeholder groups.
So Healthy Alaskans 2020 is a partnership between the State of Alaska and the Alaska Native Tribal Health Consortium. This is actually, we believe, one of the only initiatives of its kind in which a state public health department has fully partnered with a tribal entity to conduct a statewide health assessment and to develop shared health improvement goals. For a number of reasons, this was a natural partnership. ANTHC and the State of Alaska are the two primary providers of statewide public health in Alaska, and we have shared and overlapping service jurisdictions throughout our state. At the time, we had received NIFI grant funding, so federal funding, so simultaneously to do the work. So it just made sense to have this together. And furthermore, we share similar visions and similar scopes, as you see here by our mission statement. So it just made sense, and of course, by joining forces, as many of you know, then you can do more with what you have. So the guiding principles of Healthy Alaskans 2020, Healthy Alaskans 2020 is committed to using the best scientific data as well as local knowledge from our many diverse cultures. Throughout Alaska, there are over 200 federally recognized tribes, and that's part of what it made this stronger collaboration, is inputting those community perspectives as well. We try to work collaboratively and are accountable to each other with partnerships, and striving for health equity for all Alaskans, and this was very important when choosing the health priorities. Work on strengthening communities and empowering individuals and ensuring quality of life across the lifespan. So we actually want to turn this over to a couple of you. So if you could type into the chat function, what was one successful strategy that you have used to engage your stakeholders?
And Diana, while the folks are doing that, I just want to give them a heads up that it is just an open field text box, so they can type their answers in there. There is a limit to 255 characters.
Denise, does everybody see the responses?
Michael, no, they won't be able to see the responses.
Okay.
So if you want to highlight one or two of them, you can go ahead and you should be seeing the answers now.
We are.
That's great.
So if you,
what we're seeing from folks online is town hall meetings and contracts for public health service, regional meetings, defined tasks and roles. So that's great. Those are actually things that we really strive to use as well in our process. So it's nice to know we're not alone. All right, so I'm going to go on and talk a little bit about our organization for Healthy Alaskans in 2020. So you see a pyramid here on the slide. At the base of it is Alaskan communities. As I said, we have very diverse communities across a vast geographical area. And so what was really important was trying to get that community feedback. We had over 3,000 survey responses that came throughout the process of developing our indicators and developing the health improvement plan. If you move up to the next page, we had a data team, and still do, and other subject matter teams that met together and really tried to see what are things that we can move forward on in terms of our community health priorities. At the center is our advisory team. And our advisory team is about 25 people. It has guided the partnership for over 3 years and meets about twice a year. Membership has evolved as the needs of Healthy Alaskans 2020 has changed, but it includes a membership from diverse stakeholders, including our Governor's Council on Disabilities and Special Education, to Christian Health Associates, Primera, Blue Cross Blue Shield, our community health aid program directors who provide primary care in village communities, Mental Health Trust Authority, so a lot of different stakeholder groups represented. Then there's the core team, and the core team is the backbone of our entire organization. That is made up of State of Alaska and ANTHC staff members who help move the initiative forward and coordinate all aspects of Healthy Alaskans. And lastly, there's a steering team who guides at the finest tip of it, guides the process forward. So Michael mentioned the 25 leading health indicators. So I want to talk about how we got to that. Healthy Alaskans 2010 had over 100 and I think even more health indicators, and it was very difficult to track, to measure, and to see any progress and have people feel engaged and interested and feel like they had a voice. And so in this process, we knew we wanted to have fewer leading health indicators than the 2010, but it wasn't sure how many they were going to be and how that was going to happen. So the process that we used here in Alaska was to, we had starting with over 100, had a round of community of interest surveys, which narrowed it down to 71 indicators. Now these indicators, again, even that was very difficult to get it down to this, to 75, and was talking yesterday with one of the people involved, and she said, how do you choose between your children? So it was very difficult, but one of the things that helped in that process was using our guiding principles, using the criteria, especially of health equity, of prevention, trying to do upstream work. So all of those sorts of things guided us in terms of narrowing down the indicators. And that led to a second round of community of interest surveys, and obviously data team experts, subject matter experts, and that narrowed it down to our 25 leading health indicators that are now what we use throughout our state. So as I said, just to really hammer it home, because this is something that a lot of people struggle with. If you have everyone, you don't want to lose people if their indicator isn't one of the ones there. You have a personal passion, but then you really need to have something that you can manage and look at in the future. We wanted to be guided by data. We wanted to use our criteria. So I think that what's important here for all of you is deciding what you're going to do. It's really critical to think of a framework in advance and some criteria on which you're going to base it. And then that helps people who, even if their specific thing isn't there, that they still feel like it is included and they are part of the initiative in the state moving forward. So some of our highlights to date, as I said, the 25 leading health indicators were selected, and this includes health and risk factors across the lifespan, including prenatal care, immunizations, child and adolescent behavioral measures, injury prevention, and social determinants of health. We also published a strategies and actions document and some scorecards that measure the progress of Healthy Alaskans in terms of a target, and then how close we are to meeting the target. So that's something that has been really important for measuring and tracking, seeing how close we are on board. This slide just shows you a picture overall of our objectives and the 25 leading health indicators. As I said, it ranges from multiple things, from cancer, affordable health care, et cetera. So there's a lot of things in here, but this was, as a state, what we decided that we would focus on by 2020.
Diana mentioned with part of that the strategies and actions document. The strategies, we had work groups working on the strategies and actions. We had 12 topic expert work groups who worked on those for each of the indicators. And so we ended up with 75 evidence-based strategies that will help us to achieve our leading health indicator goals. Along with those strategies, there are over 200 specific activities associated with those strategies that we've identified that are already underway and taking place throughout Alaska. We also have identified 130 key partners, another stakeholder group. These key partners are organizations, other entities throughout Alaska who have either participated directly in the development of the SHIP, or they're key partners who are identified later after they heard about everything going on and wanted to be part of the action and be involved in our efforts. So here you can see this is an evidence-based strategy page. So it lists the indicator. It'll have the strategy. Each indicator will have between 1 to 5 strategies. It lists the evidence base, and then also the source, the resource of, who says that that's evidence-based? Where did that resource come from? So we have all of that available to help out everybody from planners, grant writers, policymakers, program managers, as well as anybody else working on an initiative similar to this. And again, we continue to build the understanding that the work is shared and that it's not the state of Alaska and it's not ANTHC taking on this health improvement. We recently published a document called Strategies, Actions, and Key Partners, and that's available on our website, which you will see that at the end of our presentation. This is a document that includes all the 25 leading health indicators, the strategies associated with that, as well as the actions, specific actions taking place for that strategy, and also what key partners have been identified who are involved in this work. And I really think the success of our State Health Improvement Plan to date is largely contributed to the level and quality, involvement, and dedication of all of our stakeholders. That's something extremely important, I think, to point out, and early engagement with all these stakeholders, I think, has been key to the success of our program so far. And also the successful fostering of relationships and providing meaningful engagement, I think that is attributed to several different things. Strong leadership support from our leadership. I mentioned early stakeholder engagement. Transparency is extremely important. We've been sharing all steps of the process to wide, diverse audiences, from general community members to other partners, key partners, people within our divisions, and then also having specific roles and responsibilities, which someone had mentioned in the poll that we had, that was one strategy that they used. And then also continuing to communicate with our stakeholders, because a lot of times there will be times when there's really not a lot for our stakeholders to do because we're busy trying to develop frameworks and further our vision and marketing plans, and we aren't quite ready to share those with our stakeholders, and so there can be gaps. And so we found it really important to have ongoing communication with our stakeholders just to keep them engaged, even though there's not real work for them to be doing at that time.
So all of our information is located on ha2020.alaska.gov, and that's where we have our leading health priorities, all the results of the health assessments, our scorecard, where the data came from, and that is also how we help communicate with our stakeholders.
And so what's next, really? And what have we asked of all our partners in the meantime? So right now, we continue to ask all partners to provide continued support in assisting us in moving forward by creating synergies, aligning their strategic plans or some of their other efforts with the leading health indicators of HA 2020, to help engage other partners and market it and promote HA 2020, as well as sharing their work and working together to improve collective performance around the leading health indicators as well. So we've just completed our implementation framework plan, and we're beginning a pilot implementation project. And this is really an innovative and unique implementation plan due to Alaska's health system structure, or lack of, and due to the Alaska health system being so diverse and spread out throughout the entire state of Alaska, and working with all of our different villages, many only accessible by boat or air. So, can you get this one? We utilize several resources to develop our implementation framework, including ASTHO's SHIP Development Guide. So, thanks ASTHO, that came out just in time this summer, and that's when we started developing our implementation plan. So if anyone on the call is planning to develop or implement a SHIP or have already begun implementing it, we certainly would love for you to join us for ASTHO's 4th SHIP webinar covering Module 7. We'll be presenting the details of our implementation plan then, and I think that's on Thursday, February 25th at 1 o'clock Eastern Time. So I hope this was helpful to you all, and thank you again We'll be glad to answer any questions at the end of the webinar, and please feel free to contact us directly with other questions here with the information on this slide. Thanks, Denny.
Thanks, Michael and Diana. That was really terrific, and we look forward to hearing more about your implementation plan at I think that's the final webinar.
It is.
Great. So thank you. Just a quick reminder to the audience that you can submit questions through the chat function throughout the presentations. So be sure to use that if you have questions as the presenters are presenting. So now I want to turn it over to our colleagues in Oklahoma. So James, please go ahead.
Yes, well, good morning or afternoon to you, depending on which side of the country you are listening in on. My name is James Allen, Director of Partnerships for Health Improvement at the Oklahoma State Department of Health. And I wanted to piggyback a little bit off of what we heard from our colleagues in Alaska and kind of describe our process as well as in developing our State Health Improvement Plan, and really echo the importance that they placed again on engaging community partners and really getting beyond just those partners that we may typically think of when we think about health or public health, but looking at representatives ranging from business to education to the faith community and the role that all of us play in improving health. And equally important, the role that improving health can have on helping those various sectors achieve the outcomes that they are aiming to improve as well. So what I'm going to describe to you, the name of our SHIP, first of all, is our Oklahoma Health Improvement Plan. We call it OHIP for short. And this is actually the second iteration. We have recently completed the second version of our Health Improvement Plan. So wanted to step back for just a moment. In 2009, the Oklahoma legislature passed a joint resolution that called upon our State Board of Health to create a health improvement plan for the state of Oklahoma. And I want to acknowledge Joyce Marshall, who was the director of our Office of Performance Management at that time and is now the director of our Maternal and Child Health Service, in really helping to lead and pull together the process that produced our original OHIP, Health Improvement Plan. And so the process I'm going to describe today is the process that I have been involved in updating our Health Improvement Plan, but this process very closely echoes what was done the first time around. And then the reason I mention that is because when Oklahoma was accredited, when we received our PHAB accreditation in February of 2013, it was based on that original Oklahoma Health Improvement Plan and the process. And so one thing that I would just state to you in developing your state health improvement plans for those of you who are seeking PHAB accreditation is that the process of putting that plan together is really about as important to PHAB as the actual contents itself. I could have a very wonderfully written plan, very comprehensive, very in-depth, have some great objectives and performance measures, but if I did not involve the community in pulling that together, how have I really been able to reflect the needs and issues of local communities? And so that is one variable that I just really want to emphasize, is that from the beginning, engage your communities, engage your community partners, and the diversity of populations that we serve across the state. Well, if I were to describe the development of OHIP or a state health improvement plan, I like to give this in reference to pulling three ingredients together, and that's what you see in front of you right now. We have what I call quantitative data plus qualitative data plus evidence-based practice. And what I like to do is really kind of boil those down into three tools that we use to put this together. So quantitative data, in other words, what's happening in our state? What is making us sick? What are we dying from? In Oklahoma, we do not have the best life expectancy in the country, and so why is that? What about healthy life expectancy? What conditions are affecting us? And as I break that out by population, as I'm looking at health disparities, if I'm looking at rural and urban differences, the quantitative data provides that for me, and that's our first foundation. So we compile what we call our State of the State's Health Report, which is issued by our State Board of Health and is a compilation of numerous data sources, everything from our Youth Risk Behavior Survey and our Behavioral Risk Factor Surveillance System. Many of you may be familiar with those instruments. But then we also combine that with hospital discharge data and a number of various data sources that we have around the state to put together a compendium of health status in Oklahoma, and then we benchmark this with national numbers. So we use Healthy People 2020 as our guidance document for doing that, and we break this down county by county. And we actually measure the distance between Oklahoma or a given county within Oklahoma, the distance between our numbers and the national averages, for better or for worse. And that helps us really start to look and prioritize, at least from a counting perspective. Number of deaths, number of illnesses, number of diagnoses, number of preventable hospitalizations, all of those elements come in to paint that picture of what is happening in Oklahoma. Well, and that is a wonderful resource for us, but we also need to know why this is happening. Where is this coming from? Why is it that we are dying disproportionately of cardiovascular disease? Why do we have a disproportionate burden of diabetes in our state? So this is where our qualitative data comes in, and this is a bit more labor intensive to produce. The other is a lot of work, certainly, but this really is where we need to visit with communities and get a picture of what Oklahomans are facing on a day-to-day basis, and this is where we start to look beyond just what we're seeing presented in clinics and in hospitals. This is where we really begin to pull in those social determinants of health. This is really where we begin to pull in population dynamics, where we look at socioeconomics, where we look at educational attainment, and how all of this kind of really paints, and we use the life course model really as kind of our guide. What trajectories do these kinds of physical and social conditions and experiences begin to put into place as a pathway that individuals often follow on a road to either good health or poor health outcomes? The third ingredient then is evidence-based practice, and I commend Alaska for the wonderful work that they have done in really documenting that in their State Health Improvement Plan, and would encourage all of you to do the same so that we really know what the science says about what is effective at reducing or improving X, Y, or Z conditions, so that we can really focus limited resources and approach funders, both on the public and private sector, asking for assistance in implementing programs. At least we can certainly state that these programs are based on evidence and we know them to be effective. So when we put those three ingredients together, that's what we use to develop our health improvement plan. So where I will go next is really the process that we used in putting that together. Our quantitative data, this State of the State's Health Report is a document that we've been producing for about 20 years now, and so this is a regularly occurring product of the department. It's these next two that are relatively newer in the world of our health improvement plan. So let me start with the qualitative data and the process we use to engage communities and really begin to collect information about what is happening in the state of Oklahoma. So what you see on the slide here, we did move rather quickly on putting this together. But we wanted to look at, first of all, capturing communities across the state, both large and small. And from a geographic distribution, we wanted to reach basically every corner of the state. And so we pulled together some community discussions, as you see a list there of communities where these occurred. And then we wanted to focus particularly on some populations in which we see health disparities in Oklahoma. So we held some sessions that focused primarily on our African community populations as well as on the Hispanic populations in the state of Oklahoma. And then you see listed there tribal consultations. This is a formal process that the Department of Health uses anytime we engage tribal nations in public health work. The state of Oklahoma has 38 federally recognized tribes residing within the state. Oklahoma does not have reservations per se, Indian reservations. We have tribal trust lands that are located within Oklahoma. And so tribal members in Oklahoma really do have dual citizenship. They are members of Oklahoma as well as members of their tribes. And so whenever we conduct tribal consultation, we recognize first and foremost the sovereignty of our tribal nations, and our Commissioner of Health, who is also our Cabinet Secretary for Health and Human Services, leads these sessions together then with tribal leaders or his counterparts within the tribal nations, in which we come together and have these community discussions literally in a government-to-government format. And we have a tribal liaison office that helps pull those various elements together. So you see two of those sessions listed there as well. So let me describe the content of these chats. What did we talk about? And again, a process similar to what we heard a moment ago with Alaska. It was a matter of bringing people together, and we had a facilitator that we contracted with to come in to lead this discussion, and it focused primarily on three questions. Question number one, what is your vision of a healthy community? Tell us what that looks like. And we were no more specific than that. We really wanted to let the group do some, out-of-the-box thinking, tell us what this would look like. What does a health community to you look like? And we would have individuals seated at tables, and they would just simply write down on cards what that vision looked like. They would then share these cards around the table and start to group their ideas by categories. So we started really kind of having a nominal group process in that sense. We would then take each table's list of groupings and place those on a board in the front of the room and continue with the entire room, creating larger and larger groupings to where we would end up with about 4 or 5 general features of what a healthy community looks like for a given population or for a given community where we were conducting these chats. Questions number 2 and 3 followed a very similar process. And I'm getting ahead of myself, so I need to put this slide up here. There we are. Apologize for that. So question number 2, so what is preventing us from achieving this mission or this vision? Why is it not a reality? Why is it a vision? Why is this not here today? So as you might imagine, that's where barriers began to be voiced by the group. These could range from a lack of educational and employment activities to lack of access to health care, which we heard very, very frequently. And we would go through a similar process of grouping these into categories and then trying to get a manageable number of about 4 or 5 overall topics. So we had vision, and then we had barrier. Now question number 3. What are 3 steps that we need to take in order to address the barriers identified in that second question? So here's where they started to develop some strategies. So what if one of our barriers was a lack of educational opportunities or a lack of economic opportunity? What 2 or 3 ideas can you give us that need to occur in your community to help make that happen? We wanted to be sure that we did not try to come in as the state of Oklahoma telling a local community what it needs to do. We wanted quite the opposite to happen. Tell us. No one knows your community better than you do. Tell us what's happening. And our job was to look across all of these community discussions and look for commonalities. So the challenge we had coming away from this was this large stack of, as you can imagine, answers to those 3 questions, and where do you begin with this? And as we begin to compile these, we had about a 95-page spreadsheet once it was all said and done. And so we continued to look for themes and look for ways to group and ways to categorize the outcomes or the themes that we saw in these questions. And this is what I'm showing you now on this next slide are some of those general categories. We began with health access. That was a very prominent discussion point, and so we heard everything from access to clinical services, access to preventive services, so not just sick care, but well child visits, physicals, just ways to sit down with a healthcare provider and maintain the health status that I have, prevent me from going down a road of ill health. Access to healthy foods was a significant issue. We have a lot of food deserts in the state of Oklahoma, as I'm sure many of your states have as well. We've actually begun a process where we are also starting to map the locations of those food deserts. And the reason this kind of information is so important to us, as you can imagine, if we were to just write into our health improvement plan that we need to educate the population on the kinds of healthy foods to eat, that is very helpful and we need to do that. But if we also don't pay attention to the fact that many people in the state do not have access to those kinds of foods, or their choices in obtaining those foods are limited, we've only done part of the work that needs to occur. Outlets for physical activity, very similar. I may live in an area where I don't feel safe going for a walk in the evening, or the park in town is across a 4-lane street and I'm concerned about my kids crossing that street to get to the park. Social determinants became very, very prominent. And it was interesting. In our quantitative data, that State of the State's Health Report, we would see a list of health outcomes. We didn't hear so much perhaps about those health outcomes in the chats as we heard about the social determinants that often lead to those outcomes. So again, I may not have heard about cardiovascular disease in a community chat, but I certainly did hear about lack of access to healthy foods or outlets to physical activity. Transportation, economic development, and education rang loud and clear also as social determinants that were highlighted specifically within those chats. And then finally, behavioral health came up as a prominent topic, and it did so on a couple of fronts. First of all, it came in as a leading driver of premature illness and death in the state of Oklahoma, and this matches what we see nationally. Nationally, individuals with severe mental illness who are not receiving treatment lose about 25 years worth of life expectancy. Now, if you wanted to describe this as a health disparity, that one is significant, 25 years of life expectancy. And these deaths are not necessarily directly a result of mental illness. It's due to chronic disease and chronic conditions, heart disease, diabetes, cancer. And we see many of the risk factors perhaps cropping up earlier, or some of the behavioral risk factors in the population of those suffering with mental illness or substance abuse. We also know, and this makes sense, that mental health and physical health really are part of the same system. We often have separate systems that we use to treat and address these issues, but let's face it, we're one person, one body, one system. And so if I can improve some physical health outcomes, that will also help me achieve some behavioral health outcomes. For example, if I can help somebody who's struggling with alcohol addiction to quit smoking, I'm more likely to help them with their alcohol addiction. And many in the community told us the fact that we need to bring these systems together. Within our tribal consultation, we learned a lot from the tribes. They have many promising practices that they've been willing to share with us, and especially around behavioral health and linking that to physical health, they really have this piece integrated very well. So we learned a lot from them in that respect. Wanting to collaborate with partners to help accelerate health improvement. And as a result of this consultation, we created, as part of our health improvement plan, a tribal public health advisory committee. And that committee was specifically put together to help us implement the issues that were brought up in these consultation sessions, and that has become part of our health improvement plan. So let me, as we're beginning to wrap up our time here, show you a couple of items. These are some pieces out of our health improvement plan. We tried to make the document very visual. I'll give you the web link here in just a moment. But I wanted us to be able to really have what I call an elevator conversation with someone. If I have 30 seconds, tell me about your health improvement plan. Go. You have 30 seconds. What am I going to really be able to tell them? So we wanted to visually lay this out, and what you see in front of you here is, of course, about social determinants. And so our goal with our health improvement plan is to address those adverse social determinants that are influencing unhealthy behaviors, which are then leading to our poor health outcomes. And as a companion to our plan, we created a one-page front and back document that basically outlines this, outlines our priorities, and then gives those high-level goals and performance measures so that very quickly I can get a feel for what our health improvement plan is about. So let me discuss our framework, and the framework also matches the way that we implement our plan. It's all about private-public partnerships, and so we have a statewide partnership that oversees our health improvement plan. We have 4 flagship issues: tobacco use, obesity, child health, and behavioral health. Those came about as a result of the quantitative data and then our discussions with local communities. That's how those 4 were identified. And as Alaska mentioned, it's very difficult to try to limit yourself to just a few. We could not hit everything. We could not be all things to all people. We had to be selective and hit those high-level goals and strategies. Well, we need health systems to help us do this, so we looked at health transformation, where we're looking at information technology, workforce issues in health, looking at efficiency and effectiveness, and then health education came up in just about every community we visited. And so we also have a focus on health education. And within social determinants, because that in and of itself is such a huge topic, we again prioritized, and educational attainment and job creation was really what began to focus there. And that also tied in with an initiative from our governor's office to help keep these 2 together. So the way that we operate this is we have our public-private partnership at the top. We have work groups for each of these flagship issues, as well as for our health systems and working on social determinants. And those work groups report, if you will, to that overall list of that committee, that governing council of our public and private partners. That's how we are able to monitor progress around the objectives and strategies that are listed within our plan. Now, another key that we wanted to, or connection rather, we wanted to make sure occurred was with our local communities. As you might imagine, if I'm trying to write a state health improvement plan, how does that apply on Main Street in my small town within the state? And so with our counties, many of them are involved in developing community health improvement plans, the CHIP process. Many of our counties are moving toward PHAB accreditation. And so this, as you know, is one of the prerequisites. And so we try to connect our state health improvement plan to our community health improvement plan, so that if somebody in Oklahoma sees this SHIP, the state level plan, they can also find out how to connect locally on local efforts around some of these very same types of issues that are being addressed by our Oklahoma Health Improvement Plan. So the website you see there, I'm sorry that yellow is kind of hard to read, it's ohip2020.com. You can go there, you can see the reports, you can see the fact sheet, the 2-page fact sheet that we have out. And our next steps in the process are to then populate this with the meeting minutes and the agendas of these various work groups, but then also for viewers to be able to do a county search and look up their own community and find out contact information of local coalitions that are developing those community health improvement plans, so that they can also become engaged locally. So we really try to help connect and align local health improvement plans with our state health improvement plan overall. So that was largely the process. I've not gotten into a lot of the content. You can certainly see that if you would like to visit the site. But again, I'll just reiterate, the process that is used to pull this together is very, very important in terms of both having a quality product, but then also really being able to get at the spirit of what PHAB is looking for. And they were very complimentary of our process in putting that together when we received that accreditation back in February of 2013. So I would just like to echo that the process is key in really being able to document and put this together. So I will pass it back to our host at this time.
Great, James. Thank you so much. So again, thank you to our presenters, Michael, Diana, and James. Those were really good presentations. And so now what I'd like to do is open up the lines for questions. So Hope, can you open up the lines for us?
Certainly. Ladies and gentlemen, if you would like to register a question, please press star followed by 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound key. One moment for your first question.
Thanks, Hope. So while we wait for Hope to get our first question on the line, I do have a question via the chat function. And the question is, were any non-traditional partners, examples consumers, or on any of the planning work groups? And if so, what was their role? How did they participate? So
this is James. I can go ahead and jump in with that.
Sure.
Okay. The primary mechanism at engaging consumers, for example, was first of all with our community chats. That really was aimed at members of the local community. And although we did have some service providers attend, our primary target was the consumer. And then in pulling that information together, in starting to compile the information, that was largely done through our OHIP Governing Council, but then we would release drafts of this and send it back to the participants of our community chats, as well as through the networks that were represented by the members of our OHIP Governing Council, and really putting that out for public comment. And a second approach we used, and I failed to mention this as well, because even as you saw on the slide, we were only able to reach a limited number of our communities in the state. And so we also conducted an online survey with those same 3 questions, and had that available, as well as pushing this out through our county health departments, and as I mentioned, through our website. So we really tried to hit at multiple angles the process of collecting input on the plan, and then also through a network called Turning Point, which is a network of about 69 community coalitions across the state, which really represent a pretty diverse composition of our local communities. And that was also one of our primary mechanisms for collecting feedback and input as we went through the various iterations of the plan.
Thank you, James. Michael and Diana, do you have anything to add to that question?
Well, just real quickly, one non-traditional, quote-unquote non-traditional partner that we haven't had great relationships in the past was our faith-based community throughout Alaska. And we have, I don't know, 1 billion churches. But so we have on our advisory team Brenda Moore, who works for the executive director for the Christian Health Associates. And they work with all different types of religious organizations throughout the state, including Catholic Social Services, our food banks, and different things like that. And we have them on because they're really important in addressing our leading health indicator that addresses socioeconomic status, so particularly poverty and education rates.
Great, thank you. Great question. Thank you for that. Hope, do we have a question on the line from any of our participants?
There are no phone questions at this time.
Okay. So this is a question directed directly to Alaska. Can you tell us, Michael and Diana, what data sources were used to inform the Healthy Alaskans 2020?
Sure, we'd be happy to answer that. So there are actually about 13 data sources that are used for our leading health indicators. A lot of these are statewide data sources, like the Youth Risk Behavior Survey or the Behavioral Risk Factor Surveillance System, but also including things from such as Vital Stats, American Community Survey. There's a student overweight obesity surveillance system that's used in our state, information from Office of Children's Services, and then things like crime reporting, immunizations, STDs. We have a division of environmental control and health, so oral health, hospital discharge data. So there's a lot of different ways that we get at the information that we need, and in fact that was one of the criteria for choosing the 25 leading health indicators was something that we felt that we had reliable data that we could get over a 10-year time period.
Thanks, Diana. So let me check in again with Hope. Are there any questions on the line?
Again, if you'd like to ask a question, press star 1. And there are no phone questions.
Okay. James, can you touched on the PHAB site visit. Would you be willing to share with the group some of the recommendations that came out of that site visit, particularly around your SHIP?
Yes, and I can get some additional detail on that from Joyce. I was not here at that particular site visit, but I do know in visiting with her as well and looking at the annual reports that we've been submitting. And so whenever this new OHIP was updated, we did send this back to PHAB. One thing in particular I think that they liked was the fact that we had pulled together this Tribal Public Health Advisory Committee, and that they wanted to see that, of course, our health improvement plan really was guiding our work. And so one of the things that, that we did once we had this health improvement plan in place was within our own health department strategic plan. We really built it and built our strategic map based on those core priorities within OHIP. Now, of course, our health department plan goes into some other areas as well, and some that are maybe beyond the primary focus of PHAB, such as our direct clinical services that we provide. But in really seeing that that state health improvement plan drives the work that we do, and so both our agency and then some of our other partners, we really try to encourage them to use that as one of the guiding documents in developing their strategic plans as well. So seeing first of all that we had community input and participation all the way from the top, for health directors or health department directors, whether it's state, regional, or local. It's, of course, not enough to just sign off on a plan that was put together. PHAB really does want to see that those individuals themselves were directly involved in providing leadership into the process, but then certainly providing evidence that that health improvement plan is guiding and driving the work that we're doing. We actually use that, I mentioned, to inform our strategic plan, which then informs our business plan. So we can really see from the way that we fund and build the infrastructure for our department, we can see reflections of our state health improvement plan in that process. So it's not just a report that got filed somewhere, it's actually being utilized both by the health department, but then also by our local communities. We have put together a public information officer group, which is our communication arm for OHIP. And so whenever we're dealing with public health policy or addressing that population health improvement, we are able to frequently see even the public discussing this and talking about this and seeing OHIP reflected in the discussions of our partner groups and partner agencies involved with this. So they really can see that OHIP, they want to see a state health improvement plan becoming part of the DNA, just the way in which we conduct our work. So they want to see implementation and evidence of that implementation.
So James, just a follow-up to that question, were there any lessons learned, and I know you weren't there during the site visit, but are there any lessons learned that your colleagues have gleaned from the PHAB site visit?
I think the primary piece would simply be that when we're looking at what the communities are telling us in terms of health disparities, I'll use that example. That is something that we're continuing to want to look at. We have learned that it's not just enough to look at, I'll use infant mortality as an example. We have seen a reduction of infant mortality in the state of Oklahoma, but if I begin to break that out by population or subgroup, not everybody has been reducing. Our African American population, for example, has witnessed an increase in infant mortality. And so I think the recommendation, what we've learned, is to really drill down with that data. And with our tribal nations, this has really, I think, been a learning experience for us is that they have really expressed a desire to see tribal level data, not just Native American data combined into a single category. And so because we've identified that now, we have a duty to then partner with them to explore ways in which we can achieve such data breakdowns or other issues or concerns raised during these consultations in the development of that health improvement plan.
Great, thank you. I think that's really helpful information to share for those folks on the line who may be looking at seeking accreditation. And then just one last follow-up, James, if I may, on the PHAB site visit. Is there anything that stands out, or in terms of the overall site visit, any lessons learned, particularly from the entire site visit, that you guys gleaned?
Well, certainly, being, fully aware and just knowledgeable about, all the documentation that you have submitted and being able to thoroughly answer the questions that they've come up. I mean, the better you do the documentation at the outset, the fewer questions the site review team will have when they come on site. And that's one of their primary areas of focus, is to come in with questions of where we need clarification, or could you further describe or further elaborate on what you stated in this documentation that you submitted. So the more homework you do up front, the less work or the fewer questions in some cases the reviewers might have to ask when they come out. Now they will want to visit with members of the community and people who have been involved in both your health improvement plan and just from a partnership level, who are you partnering with? And they will have a session where they sit down and ask questions of those partners. What has your experience been in working with the health department, and what has your role been in the development of this health improvement plan? And describe some examples of how the two of you have partnered around some health issues. And so this is something that it's going to be very evident, I think, the extent to which this level of engagement with partners is not just something that we do to prepare for something. This is, again, it's the air we breathe. It's the DNA of how we conduct our work in public health. And so just always be sure that's one of your guiding principles, is that we are constantly involving our stakeholders and our non-public health partners in this work.
Great, we appreciate you sharing that. We have about 1 minute left, and let me just check back with Hope to see if we have any questions on the line.
And there are still no audio questions.
Okay. So can we go ahead and take the first audio question?
There are no audio questions.
Oh, I'm sorry, I misunderstood you, Hope. Okay, great. So one last question for Alaska. In these last minute or so, in a nutshell, can you tell us a little bit more about why the partnership between DPH and the Alaskan Native Tribal Health Consortium has been so successful? Maybe give us one or two words that would explain, why that partnership has been so strong over the years.
Sure, I'd love to help. Basically, as I said, we have similar jurisdictions. We have a scope and a vision that is very similar. And in our state, the tribal health system is a vast network. We consider it a scope and hub, where there's local clinics in villages and sub-regional hospitals, or sub-regional bigger clinics, and then regional hospitals, and then a hospital in Anchorage that provides tertiary care. So a lot of the activities that we do aren't just medical. We have engineering. We have things that include behavioral health, dental health, community health programs. So there's a lot of things that are done within the tribal system, and in fact, in some communities, the tribal system is the only health system in the community, and both for Native and non-Native community members. So I think the ways in which the tribal health system help partner with the state of Alaska brings a lot of knowledge and statewide resources, and then we bring a lot of experience working within communities and gaining community participation. So that's really been, I think, the essence of the partnership and how we work together.
And we've worked together in the past, just not on this level. So I think another thing that was great is we've partnered with ANTHC on smaller projects throughout the years in the past, and that really helped us build a good relationship and trust with each other that allowed this partnership to develop.
Great, thank you so much. So it looks like we're out of time, maybe a little bit over. So again, I want to thank the presenters, our funders, and of course our participants for participating in the webinar. If you need further information about the State Health Improvement Planning resource or other topics related to performance management, quality improvement, or accreditation, you see before you my contact information. Don't hesitate to reach out to me. And once again, we value your feedback, so please take a few minutes to provide us with your feedback on today's webinar. Once you log out, you will be directed to a survey. And thank you all. That concludes today's session, and have a great day.